morning, everybody. Today, we are talking about prediction and prevention of cancer-associated thrombosis. As you know, 15 to 20% of cancer patients experience one or more episodes of venous thromboembolism during their cancer journey. Approximately 80% of all cancer-associated thromboembolism occurs in non-hospitalized patients, and routine thromboprophylaxis for these patients are not routinely recommended by international guidelines due to high heterogeneity of these patients. There are other difficulties as well, like stratification of high risk patients and uncertainty during their prophylaxis treatment. Although international guidelines have endorsed stratification scoring system known as Khorana score for estimating thrombotic risk in ambulatory cancer patients, but it seems that it is more discriminatory in performance and not completely convincing, with varies according to the cancer type. Consequently, a minority of ambulatory cancer patients receive exact treatment for prophylaxis. So today we are going to discuss how to predict and prevent thromboembolism in this setting. This is my disclosures. Objectives of today's talk is to identify the risk of thrombosis in ambulatory cancer patients and to identify those patients who can benefit from prophylactic treatment. We will discuss type, dosage, and duration of anticoagulation for primary prevention of cancer-associated thrombosis today. The incidence of cancer-associated thrombosis is 117 per 100,000. The annual incidence in cancer patients is 1 in 200, 4 times more in cancer patients than in general population, and 6.5 times more in those patients who are undergoing chemotherapy. As you know, malignancy and venous thromboembolism go hand in hand. Bleeding risks are also very high, is the leading cause of death after the cancer. It has led to increased morbidity and hospitalization burden. There are also bleeding complications due to anticoagulation treatment. There is also increased chance of recurrent thromboembolism in these patients. And with VTE, cancer treatment delays are likely, which can affect the outcome of the patient. VTE is the second leading cause of death in cancer patients, first being cancer itself. With the diagnosis of VTE in cancer patient, the chances of dying rises exponentially. An analysis of 1.2 million US Medicare patients have found that malignancy and VTE is the top cause of deaths. The mortality rate varies from cancer to cancer. The VTE in certain kinds of cancer patients occur more frequently, like pancreatic cancer, lung cancer, and upper GI cancers. But the risk of VTE in breast cancer and prostate cancer is minimal. Similarly, the risk of VTE rises in certain histological types of cancer in the same type of cancer. For example, adenocarcinoma is more likely than squamous cell carcinoma of lung to develop VTE. Similarly, ALK mutation and ROS mutations are more likely to get thrombosis than the squamous cell carcinoma alone. In the same cancer patient journey, the risk of thrombosis rises and reduces. With the cancer progression, the risk of thrombosis goes up, and when the cancer comes in control, the risk of thrombosis goes down. Similarly, when they get chemotherapy and immune checkpoint inhibitors or target therapies, their chances of VTE rises as well. There are certain factors which can influence the chances of VTE, for example, prolonged bed rest, surgical procedures, and local pressure, direct on direct damage to endothelial cells by chemotherapy. And there are certain patient factors as well, like age of the patient, comorbidities, and cancer burden. Blood compositions are also very important in terms of cancer risks, like leukocytosis and use of erythropoietin. The prevention of VTE in cancer patients can be divided into three scenarios. One is those patients who are undergoing surgery, and the second one is those patients who are admitted in the hospital for any medical reason. And the third one, those cancer patients who are ambulatory and undergoing chemotherapy. There are well established guidelines for perioperative VTE prevention and VTE prevention for cancer patients admitted in the hospital. But there are no significant work or guidelines available in those patients who are ambulatory, although bulk of VTE is happening in non-hospitalized patients. This is a scenario of 60-year-old male who developed cough and blood in the sputum. Imaging and histology has confirmed non-small cell lung cancer, which is locally advanced. His oncologist has recommended systemic chemotherapy and an immune checkpoint inhibitor, but was worried about possibility of venous thromboembolism and have consulted you to evaluate the risk of venous thromboembolism in this patient. What could be the answer? We have to evaluate parameters of this patient. There are no personal or family history of VTE. He is uh, diabetic and having hypertension. There is no positive findings on physical examination. His BMI is normal. Lab parameters have shown hemoglobin 11.5 and WBC is 12 and platelets is 400. So what could be your answer? Number one, reassure his oncologist that he has no history of VTE and nothing to be done. Number two, evaluate risk of VTE by using predictive scores like Corona scores and recommend prophylactic anticoagulation if score is high. Number three, recommend prophylactic anticoagulation for all cancer patients undergoing chemotherapy to mitigate risk of VTE. The best answer for this question is B. First, heparin was used and subsequently warfarin came in, and low molecular weight heparin was a standard of care for last 25 years. And now direct oral anticoagulants are standard care in cancer patients. In the beginning, there were some trials in prophylactic settings with low molecular weight heparin. These was in unselected patients of different types of cancer patient. For example, pragmatic trial was in cancer patients which were locally advanced, metastatic, and early lung cancer patients. And they were given low molecular weight heparin 5,000 units twice a day versus placebo. There were recent meta-analysis of these trials in which 26 randomized controlled trials involving 12,352 patients were evaluated, and it has shown that low molecular weight heparin was successful in averting VTE about 2 to 3%, but the rate of major bleeding was also a problem in these patients who are undergoing low molecular weight heparin treatment. The major guidelines did not recommend VTE prophylaxis in all ambulatory cancer patients, although there was some evidence that low molecular weight heparin was effective in preventing VTE in 2 to 3% of patients. But the problem was number to treat were quite high and they were above 50. And there were low VTE rates in placebo group as well. And majority of these patients were unselected. And daily injections were not preferred by patients. And the patients with high risk of VTE can be separated from those patients who are at low risk of VTE. In that case, we can reduce number needed to treat. Recent guidelines from most bodies, including ASCO, have recommended conducting VTE risk scoring system like Corona score. Corona score is a predictive score which take consideration of cancer type, blood counts, and body mass index. This can be divided into three categories with Corona score 1, score 2, or 3 or more. There are good validation studies supporting Corona score, showing low score of 0 with incidence of VTE 0.3 to 8%, and intermediate risk score 1 to 2, 1.8 to 2% risk of VTE, and high score of more than 3, leading to 6.7 to 7.1% of VTE. The Vienna cancer and thrombosis study has further validated it, and the intermediate risk were defined into high category and lower category. There is further meta-analysis of trials from 208 to 218 showing low risk of 0 Corona score to 5% and intermediate risk score of 1 to 2, 6. However, the utility of Corona score is limited by smaller proportion of patients included in both low and high risk categories in comparison to the considerable proportion of patients coming in the intermediate category. Furthermore, the accuracy of Corona score varies across different types of cancers, with remarkably low performance in patients with hepatobiliary or pancreatic cancers and lung cancers. Furthermore, it has been suggested that estimation of absolute benefit of Corona score in reducing VTE risk could be overestimated about 23%. These are the reasons that predictive performance of Corona score is questionable. Therefore, there is further refinement of Corona score by uh, Protect score, Conco score, and Oncotave score. There is also Compost CAT score and CATS-MICA score with addition of D-dimers and other parameters. This is to improve the predictive performance of scoring system, but these scores are not yet validated. Recently, Corona score more than two and more than two criterion has been adopted for identifying ambulatory cancer patients who are at intermediate and high risk of VTE in two large randomized controlled trials with placebo control. And these were AVERT and CASSINI trial. The result of these trials have shown that relative VTE risk reduction with antithrombotic prophylaxis is 2.8% in Cassini study and up to 6% in Everett study with a not significant incidence of bleeding versus placebo. In both trials, all-cause mortality was similar between dogs and placebo, although the efficacy and safety of antithrombotic prophylaxis was demonstrated in both studies, but high number needed to treat was found, about 40 in number. So we will just go in little details about Cassini and Avert trial. So this is the design of a Cassini trial where 841 patients were randomized between rivaroxaban 10 milligram versus placebo. The primary efficacy endpoint was symptomatic or screen detected proximal lower extremity DVT or PE or symptomatic upper or lower extremity DVT or VTE related death. The primary safety outcome was major bleeding as defined by International Society of Thrombosis. And this is the design of Evert trial where 563 patients were randomized between apixaban 2.5 milligram twice daily versus placebo. And the primary outcome was the same as with Cassini trial. This is the result. Primary endpoint analysis included events occurred as a primary endpoint on either study. On treatment analysis is only including events occurring while on the study drug and up to 2 days after the last dose. So if you can see here, the both drugs were successful in preventing significant number of VTE in cancer patients. This is the outcome of major bleeding. The major bleeding were not significant statistically. There was sub-analysis and pooled analysis. Both studies were combined, and the pooled analysis shown that both drugs significantly reduced VTE as compared to placebo, and hazard ratio was 0.55. Drugs did not statistically increase the risk of major bleeding, and hazard ratio was 1.96. And the sub-analysis have shown that pancreatic cancer is well known to be a cancer of strongly associated with risk of venous thromboembolism with rates ranging from anywhere between 10 to 30% depending on the stage. There have been so these two studies were successful in showing these high risk patients. Subsequently, there were some guidelines from ASCO. The high risk ambulatory patients with corona score more than 2 or 2 starting new systemic chemotherapy may be offered thromboprophylaxis with apixaban, rivaroxaban, or low molecular weight heparin provided there is no significant risk factors for bleeding and no drug interaction. It should be accompanied by discussion with the patient about the relative benefit and harm, drug cost, and duration of prophylaxis in this setting. There are international guidelines from various bodies. For example, International Initiative on Thrombosis and Cancer in 2019 suggested apixaban or rivaroxaban for primary thromboprophylaxis in high-risk ambulatory patients with corona score 2 or more than 2 who are starting chemotherapy if no contraindication or drug-to-drug interaction. This treatment can be given up to 6 months, and treatment decision should be made after considering the risk of VTE and bleeding as well as patient preferences. Low molecular weight heparin should be considered if apixaban and rivaroxaban are contraindicated in these patients. How to mitigate the risk of VTE in cancer patients? The ambulatory cancer patients have variable risk of VTE, and they should be assessed on individual grounds for VTE risk prior to initiation or during the course of systemic anti-cancer treatment using validated assessment score. The ambulatory cancer patients with corona score more than 2 of thromboprophylaxis can be considered up to 6 months by using rivaroxaban or apixaban or low molecular weight heparin. In myeloma patient receiving thalidomide or lenalidomide-based regimen, it is recommended to use VTE prophylaxis during the thalidomide or lenalidomide-based regimen, and suggested types of anticoagulation could be low molecular weight heparin, aspirin, apixaban in this scenario. There are risk factors which can be studied in each individual patients when evaluating it. There are tumor factors, for example, adenocarcinoma or squamous cell carcinoma, and also ALK mutation and ROS mutation in lung cancer are more likely to have thrombosis. And similarly, there are patient factors, for example, BMI, age of the patient, comorbidities, and frailty. And similarly, there are certain types of cancer like pancreatic cancer and upper GI cancers, which are more likely to develop VTI. Thromboprophylaxis in unselected patient receiving systemic anti-cancer therapy is not. It can be categorized into three categories. Number one, ambulatory cancer patients who should be offered antithrombotic prophylactic treatment, for example, pancreatic cancer. Number two category is ambulatory cancer patients in whom antithrombotic prophylaxis should be considered. These are lung cancer and gastrointestinal cancer, especially upper gastrointestinal cancer, as they are more likely to develop thrombosis than lower gastrointestinal cancers. Number three category is ambulatory cancer patients in whom antithrombotic cancers should not be given or should be considered with extreme caution. For example, glioma, brain metastasis, and those patients undergoing chemotherapy who can develop thrombocytopenia, and patients who develop severe renal impairment. Implementation science is a separate science which need further consideration. There is always a question how to implement the evidence and when and whom to give primary prevention. There was a suggestion of starting a dedicated cancer associated thrombosis. An automated alert may be having a value in early detection of DVT in cancer patients, leading to early intervention and could potentially prevent VTE related morbidity in future. A built-in corona score into electronic medical record and outcome evaluated on that basis may be helpful. The alert function in real time is suggested in certain centers. This is my publication and Professor Noble's publication. There are some unmet needs and future perspectives in CAT, and additional research is warranted in several clinical scenarios to help clinician on the best therapeutic approach, and CAT clinic may be a solution. These could be drug-to-drug interaction, patients with thrombocytopenia, hematological malignancies, hepatic insufficiency, renal impairment, risk of bleeding, brain metastasis, end of life care, PICC line associated thrombosis. Now, what does the CAT service offer at University Hospital of North Midlands? We have now 1 year since the start of CAT service in our hospital. This is a joint oncology and hematology service. Decisions regarding duration and choice of anticoagulations are made. There is a monitoring of anticoagulation if needed. The decisions regarding interactions and managing complications, follow up by specialist anticoagulation nursing team, and patient counseling and advice is given. There is also shared care and primary care advices. The dedicated CAT MDT is happening every week for complex thrombosis patients, and this service is also looking for cancer associated thrombosis prophylaxis in future. There is a major unmet need, and one of the most important is fear of bleeding from anticoagulation. Due to prevailing fear of bleeding, effective prevention of thromboembolic events through optimal anticoagulation remains a real world unmet need. The future is promising. We know that we have come from the last century, from heparin to warfarin, low molecular heparin, and directly acting oral anticoagulants. And now we are heading towards anti 11 factor inhibitors. There are certain trials ongoing in phase 3 settings, like Magnolia trials, and these are looking to assess efficacy and safety of factor 11 inhibitors in patients with cancer associated thrombosis. Considering their pharmacokinetic profiles and potential advantages in terms of safety, this new category of anticoagulants could be new frontier. This is the cascade of thrombosis, and the anti-11A factor acts on this side, and this could result in a new kind of drugs development for clinical use. So in conclusion, in the absence of high bleeding risk, primary thromboprophylaxis should be recommended in patients with pancreatic cancer and probably in patients with lung cancer harboring ALK and ROS translocations. Patients with upper gastrointestinal are at high risk of VTE, but a careful assessment of bleeding should be made before deciding on antithrombotic prophylaxis. Primary prevention of VTE is not recommended in all cancer patients due to increased risk of bleeding. And thank you very much for attending today's talk.